My name is Daniel Cheris. The name of our practice is Arizona Desert Ear, Nose, and Throat Specialist, and today we're going to be talking about in-office sinus procedures using the Acclarent TruDi navigation system. So let's just go ahead and review the CT scan of this patient. So we'll start with just a look of the coronal cuts here. We're going to enlarge it just a little bit. So if we go right onto that head, we can make that a little bit bigger. All right. And so this is a patient with a left septal deformity, which is fairly low, indenting and contacting the left inferior turbinate. There's a left concha bullosa, turbinate hypertrophy. He's got narrowed maxillary sinus outflow tracts. He's got a crowded infundibular space and middle meatus. Here's the frontal recess. Here's the frontal recess on the other side. There's some osteitic change, which I think is important to note. What that tells me is that mobilizing this tissue, resecting this tissue, could be a little bit more difficult. Start to see a little bit more osteitic change here and in these turbinate bones as well. So I'll expect that to be probably present throughout. I'm not seeing any dehiscence of the lamina papyrica. I'll appreciate the anterior ethmoid arteries, probably there and there, not dehiscent from the skull base. We'll get a sense as much as we can of the intrasinus anatomy. And we'll go posteriorly. And we'll go ahead and we'll look at we'll start at the top here. We'll just go through here. No disruption of the posterior table of the frontal sinus. The axials are particularly helpful to get a sense of the insertion point of the intersphenoid sinus septum, the position of the carotid canals, make sure those are well covered by bone, especially if sphenoid sinus procedures are being contemplated. Okay. And then, of course, the sagittal cuts are particularly helpful for the anatomy of the frontal recess. So starting on the right, kind of working towards the left, we can see what looks to be a frontal sinus tract there. And as we approach the other side, it looks like there's a fairly prominent Agar-Nazi cell here. There's probably the frontal sinus tract, and that's where we'll probably have to access things, right between the skull base and the top of that, what I suspect to be an Agar-Nazi cell. Okay. So now we understand what the anatomy of the sinuses are, then we can talk about what the goals for this patient are. Now, this patient is a 29-year-old patient with a history of recurrent sinus infections over many years, treated extensively with antibiotics, oral steroids, nasal steroid sprays, antihistamines, saline lavages. He's had his allergies treated as well. Sometimes the antibiotics and steroids are effective at relieving the infections, but then the symptoms return once the therapy is discontinued and stopped, and that's been a recurring cycle for quite some time. And so what we're seeing here now isn't so much a state of chronic sinus inflammatory change, but this is a patient with recurrent acute sinusitis, and so we're going to go ahead and plan to treat whatever sinus we can. And so what we're able to do is to set planning points and radio beacons. And what the planning points do is allow us to select, yes, this is the area we want to be in, or you can see as I push the right button, there's a green and a red dot. The red would be something I want to avoid. And so, for example, if I saw a dehiscent carotid artery, a dehiscent anterior ethmoid artery, I would probably mark that with red. I could go ahead and I could mark the orbit and the brain in red too, but I'm not going to do that today. What I am going to do is I'm going to mark this point right here in green, because this is the left maxillary sinus outflow tract. That's where I want to be. Right after that, I'm going to go ahead and put a radio beacon in. And the radio beacon, what that's going to do is going to give me auditory feedback right as that wire passes through it. And that's going to be another way I understand that I'm where I think I am according to a point that I've already planned out. We can do the same thing. Here we see the uncinate. We see part of the ethmoid here, and so I can go right there and say that's exactly where I want to be and put my points in. We can do that for the frontal as well. And it doesn't really matter. We can do the frontal on the sagittal. We can do it on the coronal. It doesn't really matter. Now, this was the side where he had that auger cell. And so here, this it almost looks like it's going to be easier to see. If I go on this crosshair here, and I can move that up, I'm getting to where I think that frontal sinus ought to be, which is continuing into there. And so I can go ahead and put my planning points, and I'll just do it this way. This is where I want to be. And I would say once we're here, I'll put my radio beacon in here this time, because then I know if that happens, then we're golden. Okay. Let's go to the other side. And I'll just scroll through this. A little bit more to get exactly where I want to be. Okay, and to me this looks like the path that it's a little serpentine, but that's probably where we want to be. The left sphenoid, I will tell you, is a little suspect for me. That septal deformity is going to make it a little more challenging. So I'll go ahead and map it out, but I would say better odds than not we won't wind up actually doing it. We'll just mark these. We can even zoom in while we're doing this if we think that that's going to help. And I think right where that indentation is probably where we need to be. All right, let's zoom out. And then what I typically like to do is to check the height of the sphenoid marks that I've made on the sagittals so I can get a sense of the sphenoid face in that sagittal plane. So I'm looking at my planning points with respect to the skull base. And we can see that on the right side, and then as we scroll through, we can see that on the left side as well. And so whenever I plan a case out, I'll typically mark the apertures for all the sinuses because I want to be prepared to do whatever sinus I feel is going to be necessary or achievable at that setting. What I don't want to do, in other words, is wish I'd planned a point out and then have to kind of break out of what I'm doing to try to plan a new point in the middle of the case. So I'll always mark everything out. What we actually wind up doing, maybe we'll get 4, maybe we'll get 2, maybe we'll get 6. But like I said, in this one, he's got some difficult anatomy in the right frontal, in the left frontal. We're going to note that, and he's got just a bent septum, which is going to make accessing that left sphenoid a little bit more challenging. And so I'm just going to keep that in mind as we're doing it. But this would be the planning points that we've mapped out now. When we perform sinus procedures, we're looking endoscopically to see tools and instruments go into a sinus. Image navigation gives us the capability to see radiographically on sagittal, axial, and coronal planes of where our instrumentation might be going. The idea of a virtual camera sitting inside of a sinus to allow us to see what's happening on the other side of the osteal wall is a functionality called TruView, and that's what TruDi has built into it. Imagine yourself as a little person living in a sinus, and you wanted to see a wire come through the opening of the sinus kind of towards you. That's what we're doing now. We can set the camera to be anywhere we want, looking at any aperture we want. And in this case, we're setting a sphenoid sinus camera, and we can actually see the dots that I've positioned. And so if you look on this screen, imagine we're now inside the sphenoid sinus, and we're going to see a wire past that yellow and green dots coming in towards us. And that's the TruView system. The idea of setting virtual cameras positioned anywhere in the sinuses to visualize instrumentation passing the natural os of the sinuses is exciting because it allows us to see what's happening virtually in places that we can't look at with standard endoscopic techniques or cameras. What we've done here in the left sphenoid sinus is set a camera to look at the natural os of the sphenoid sinus, which I can see. Furthermore, we can see that it's narrowed. Finally, we can see the dots that we've placed here actually residing within, properly, that natural os. What this allows us to do then is this camera is now, think about this, inside the sphenoid sinus. I'm going to be looking endoscopically at a wire going away from me into a sinus. I'm going to be seeing on the CT images that that wire is going into the sinus, and then I'm going to see a virtual camera inside the sinus of a wire coming towards me. And that's what this TruView system allows us to do. The procedures that we perform in the practice are performed awake under topical anesthesia. Patients will receive a prescription for 5 or 10 milligrams of diazepam, which they'll take about an hour before the scheduled time of their procedure. On arrival at our office, they're brought back to a room and sprayed with topical anesthetic in a manner very similar to how they would be as if they were having just a routine nasal endoscopy. It's a mixture of tetracaine 4% with oxymetazoline mixed in equal proportions. After several minutes after they're sprayed, we have pledgets that are soaked in the same mixture, and the pledgets are inserted by either an MA, myself, or our nurse practitioner. In the procedure room, I'll remove those pledgets. I'll feel the inferior and middle turbinates with a caudal elevator, and I will place small pieces of cotton into the middle meatus that are soaked in the same mixture of 4% tetracaine and oxymetazoline, again mixed in equal proportions. Another pledget gets placed into the nose between the septum and middle turbinate to numb up the face of the sphenoid sinus. When we begin the procedure, that's all removed. The patient at this point, 90 to 95% of the time, won't feel anything. For the remaining 5 to 10% of patients, we can use an injectable lidocaine 1% with epinephrine 1 to 100,000 where needed in the lateral nasal wall or middle turbinate. Now it's going to navigate in real time the tip of the wire, so I'll position the tip of the wire right at the guide. And then with the scope we can look up, which is helpful. Okay, and we can see that navigated directly into the frontal sinus. We can see that endoscopically by looking at the wire, and we can see that on cross-sectional imaging where the wire is. And so we'll go ahead and we'll advance the balloon delicately. Okay, we're going to have an inflation here. We're going to feel a little pressure. Go ahead and balloon up. Okay, down. And then we'll have a second inflation, and I'll lower this down to where the green line is. Go ahead and balloon up. Down. Okay. And so we can actually see that wire very nicely in the frontal sinus. Treating a concha bullosa, I think, is always important. And while typically in the operating room I might resect the lateral lamella, in the office we'll take a less aggressive approach and we'll simply use a duckbill type of an instrument to help treat that, which not only eliminates some of the obstruction, but of course makes accessing the maxillary sinus a bit easier. Suction. So we'll note pertinent anatomy, and we see the uncinate process, ethmoid bullet. I often find it helpful to take a Lusk seeker and just pull back on that uncinate just a little bit. And that makes a little bit more space. That lets the tip of that guide get in a little bit easier. We can see that now in the maxillary sinus. We'll just position that in standard fashion. Go ahead and balloon up. Down. So we had noted the presence of an accessory os, and I think what we've done here is connected the accessory os using the balloon as a tool to do that to the natural os. And so we get a nice circumferential inspection of the maxillary sinus there. And now we're in. Okay, balloon up. Down. Okay, balloon up once more. Down. Yeah, okay, good. Okay. Enabled us to access a sinus that was difficult to access because of some anatomy.